I think networks are the most important things when you're actually thinking about going mobile. If you design or build your network only to handle text-based traffic to deliver your EMR to the cow, you're going to find yourself opening your ceiling several times. Because the next thing you're going to want to do is add something like voice over IP and converged communication services to your IP network. And then the next thing you're going to want to do is talk about real-time location services. So when you actually design the network, rather than reopening the ceiling 3 times in 6 years, think about the capacity that you want to put in there and think about how you want the network to perform in the future. Opening ceiling tiles in hospital environments is very expensive. It's much cheaper in the Intel office to do this. But you really want to think about what problems are you trying to solve and what do you want your network to do. Roaming is huge. If you're really going to use mobility, you want it to be available all over your campus. You don't want dead zones. You don't want places where throughput goes down. You don't want places where doctors lose connectivity and sessions time out and they have to relog in. You want to use software that actually maintains the session when it drops connectivity and then seamlessly finds it. Best example of that in most of your environments is Outlook, when the mail system, so that you don't know when it goes online and offline. It looks for a hotspot, it saves your work in the background and reconnects. In a medical environment, you don't want data that's out of touch. So if the application goes offline, it would be better if it didn't time out, if the session didn't time out, but you wanted to know that you're now using cached data. So, and you also have to worry about security. But do you have to worry about all of these things with equal? Well, no. It depends on, what the workflow is. If you're roaming in a hospital environment, roaming aggressiveness is huge. If you're roaming in an office environment, you may end up crossing 3, 4 APs in an 8-hour work shift. Often what you do is you're working in one office, you close your laptop, you go to another one. But a nurse who's wheeling her cart up and down the hallway, she's going to be crossing access points constantly. And a doctor who's carrying that tablet around, or a nurse who's carrying it through the campus, might cross 20, 30 access points in several subnets. Now, if you start to time out and you get blacklisted by your access points and you have to log off and clear your cache, you're going to have a real problem with that. So you actually have to look at that in your network design. That probably, to get mobile going in the hospital, is the most important thing. And authenticating those devices to keep security on the network is huge. But once you get the authorization and the authentication, do you have to use a VPN within the hospital? Probably not. But if you're going to roam outside the campus and you're going to log in remotely, absolutely. Different levels, different throughput requirements. So this is just a way to kind of look at the requirements and what you want to pay attention to between, if you're working in the hospital, you're working around the hospital, or you're working remotely from an office attached to the hospital. If I think about mobile workflow, here's some kind of do's and don'ts. Understand what you're trying to do. That's the #1 message if I don't leave you with anything else. Look at the workflow that you're trying to change. Look at the processes. Look at the stakeholders involved. Get their input. Get them involved. Then look at the network design. Then look at the software. Then look at the hardware technology. Okay? Understand what that workflow is going to do, have ripple effects. If you start to deploy mobile point of care for CPO e-order entry, what's that going to do in the pharmacy? What's that going to do to medication administration? There are going to be ripple effects down the workflow. Okay? Seek input from everybody you can. Be as inclusive as you can, because changing mobile workflow probably affects everybody within the hospital. Okay? And things not to do. Don't make your decisions from a technology perspective. It is about the workflow. It is about the stakeholders involved. Get people involved. Don't ignore the vendors. They can help you. They can help you understand what the technology is and how to do it. Set up service level agreements to make sure that the technology delivers on the promise that you're asking for, and hold people to that service level agreement. Ask lots of questions. Don't assume. In order to get people to stay at home and to care for people at home, it's my opinion that at a minimum you have to do 5 things. I think the video conferencing is essential because it establishes social connection between you and the patient. It's a way to establish trust in a remote environment. Okay? I'm not necessarily even talking here about diagnostic quality video so that I can use high definition video or derm cameras. I'm really talking about a way to establish a connection between you and the provider. That I think is the first thing that it needs to do, so that that person is comfortable. I think that the technology has to be extremely simple to use. It has to be made so that an 80-year-old can use it. My mother gets confused using an answering machine. In fact, she doesn't know how to delete messages. So about every 2 months, her answering machine stops working. And when I visit Florida, my first job is to delete her messages and get her answering machine working again. So has to be designed so that using a touch screen and simple technology, my mom can launch a video conference, can interact with that provider. So we built it for someone who is arthritic, has a Parkinsonian tremor, macular degeneration, and is deaf. Okay, this is not built for your kids. Okay, we built it so that integrated sensors can end up talking to it. So the video conference is one thing. You have to be also able to automate the process of chronic disease management. You have to interview the patient in an automated fashion by asking them questions that are specific to their chronic disease. If all you're trying to do is treat hypertension or diabetes, you're probably not going to be that successful, because the real patient in the real world is not a patient with one disease. 20% of Medicare patients have 4 diseases or more. 4. And they're responsible for about 9 visits per year to doctor's offices. Those are the really expensive people I want to try to keep at home. So the real patient I want to build this care plan for is not just a diabetic. It's an obese, hypertensive, agoraphobic diabetic with a peripheral neuropathy and a foot ulcer who now has a sinus infection. That's a real patient. And so I want to be able to interview them in a fungible manner so that the care plan can respond to their questions and the algorithms can change depending on their answers. I want to be able to inject education so that that person will absorb that education. If I want to talk to them about how to use an inhaler, I want to do it in a manner that usually something like a video. If I leave literature or I send up a static website and ask them to read it, remember I already said they may be vision impaired, okay? Their attention span may be diminished. I want to give them something that's entertaining and engaging and has a chance of changing their behavior. And I want to give it to them at a teachable moment. I want to empower them with information and knowledge. So again, the best time to teach them about breathing problems is when they're having a breathing problem. Once you establish it's not an emergency, teaching them how to use their inhaler, how to do pursed lip breathing, that's the right time to do it, not when they're in your office and they're calm. Okay, not only do I want to use the sensors, but now I want to take physiologic information from those sensors, hopefully in a continua compliant manner, and deliver it to the device. Our device at the moment isn't continua compliant only because the device was certified last summer, and as I mentioned, the continua standard came out in January. Our next iteration of the device coming January will be continua compliant. So video conferencing, fungible care plans, teachable moments, and physiologic information that helps inform the care plans. And then as a fifth thing, setting up reminder systems that you can feed back to the patient to keep them on task. 50% of patients when they're discharged from the hospital probably don't take their meds in the correct manner. And within 4 months, it's probably closer to 90%. And that leads to extreme recidivism and readmissions to the hospital. If you can only get people to take their medicines, to become adherent and compliant to their regimes, you can make a difference. So building in a reminder system can happen. The back-end software takes this information, structures it, and presents it to a nurse or a doctor who might be monitoring this patient in a manner that they can manage them by exception. They can pay attention to the people who are abnormal. Red data comes up, either from an abnormal physiologic parameter, an abnormal response to a question, or even an abnormal response to a reminder. She forgot to take her medicines. That could be more important than the fact her blood pressure has changed. The reason it's changed is she forgot to take her medicine. So you're calling her or responding to her because of the reminder system. So putting those 5 things together, I think we might have a chance to manage people at home, keep them, decrease their visits to the hospital and decrease their visits to the doctor, and managing them in lower cost environments. And cost is becoming, as we know, a huge imperative within our healthcare system.